All right. So Dr. Manus Donahue was trained in physics and in philosophy at Duke University. He has a PhD in biophysics from the Johns Hopkins University School of Medicine, and he completed a fellowship in neurology at Oxford University. He is a professor of neurology and assistant vice chair for research at Vanderbilt Medical Center and Vanderbilt University Medical Center. He also holds an MBA and is CEO and president of Biosight LLC, which operates as a clinical research organization. His interests are to develop and apply novel imaging approaches of the circulation, and he works closely with academic and industry partners to incorporate these new measures of tissue physiology as endpoints in clinical trials and as part of standard of care protocols for diagnostic imaging.
Yeah, thanks for that nice introduction, as well as to the organizers for the invitation to speak today. I'll go ahead and get started. I'll assume that everyone can see the slides. Just let me know if there's something that's wrong with them, obviously. But yeah, thanks again for the invitation. And today I'm going to be talking about clinical cerebrovascular reactivity mapping and how that can be applied to improve care in patients with cerebrovascular disease. These are my disclosures. None of these are relevant, aside from the fact that the funding for this study was provided by the National Institutes of Health. So just getting started, clinical cerebrovascular reactivity imaging, you can kind of think of this in a few different ways. So one of the ways that us as researchers think about it is, CVR mapping, some of the nice protocols that we just heard about applied in patients. And then you can also think about, maybe you take a clinical scan and then you will, things like FLAIR T1, T2s, and then you'll append like a research reactivity protocol to that in the hospital. But still, it's kind of a research scan that you're doing. And this is where most of the field remains, I think, and that's fine. That's still a lot of what we do. But what I'm going to be talking about today is really clinical reactivity imaging. So this is the idea that a patient, who is sick is referred for a clinically indicated reactivity scan. That patient scanned in the radiology department, and there's a referral from a treating clinician with the idea that that information is going to be used to change management for that patient. And the scans, are billed to insurance. They're dictated by radiology. They're uploaded to the database and that sort of thing. So this is kind of what I'm going to be focusing on today, and what are sort of the practical considerations and benefits of doing this. So if you're at your institute, how would you think about this becoming a clinical protocol? And there's really no single requirement, but there are several considerations. So, the first question that's really important is it clinically indicated and can be used to change management? So this is something that we don't always think about as researchers. But if you think about patients with like atherosclerosis, major stroke risk factor, neurodegeneration, Alzheimer's disease, MS, so forth, those are conditions where we need, improvements. But, in the case of neurodegeneration, we don't have great treatments for those patients. And in athero, we actually do know how to manage a lot of those patients. So if you have a new method, it may not really affect the management of those patients. Whereas you have good potential in some other conditions, and this isn't exhaustive, but things like moya, which I'll talk about, sickle cell, rare disorders where you don't know how to manage those patients, also children. And then to make it happen, you need clinical interest. And that interest doesn't necessarily need to be from radiology. It really needs to be from the referring clinicians. So people in like neurology, neurosurgery that are managing these patients. And then again, you need kind of ideal applications, potentially where the information that you're going to gain is going to be used to change the care for that patient. And I'll talk a little bit about that today. There are also financial interests. For people that are starting out in this field, it's interesting to know some of the numbers behind these scans. So in the United States, and I think most Western countries are similar, a non-contrasted head MRI costs about $3,500 US. You add an angio onto that, it's now up to $7,000. The operating costs for those scans are a couple $100. So there's generally about a 20-fold increase in what's actually billed for these scans. And for the radiology departments, they are really machines that print money for the most part. So what's interesting about CVR is that there's no unique billing code. So what that means is you can add it on to a typical MRI and it doesn't cost any more money. And that's good for the patient. It's also good for the referring clinicians, but it might be bad for the radiology department because they don't make more money on it. So that's something that has to be considered. And in considering that, you really need to think, is this something that's going to be good for the patient and for the institute by really changing care and potentially sort of guiding an interventional procedure or changing management for that patient? So just again, to kind of reiterate kind of what good and bad applications might be currently, not always, but currently for some of these things. Things like atherosclerosis, that's a major stroke risk factor, obviously, but we know how to manage those patients for the most part as a result of clinical trials. So, they're not actually such great applications for new imaging currently. Also, you have things like neurodegeneration. That's, horrible conditions that we don't know how to treat. But unfortunately, we don't have good treatments for these patients. So even if you show that the reactivity is impaired or preserved, it may not really change the management of those patients just yet. So, it's still very much in the research domain. And what I want to be talking about is cases where the treatment is really uncertain, but we do have emerging curative or disease-modifying treatments for patients like non-atherosclerotic stenosis, sickle cell anemia, maybe acute stroke patients outside of thrombectomy window. So I'm going to be talking a little bit about where this reactivity mapping might fit in with some of these patients. Okay, so I was anticipating that Dr. Chen would provide a nice overview of reactivity, and she did. So I don't have too much on as a background on reactivity. What I will say is, just so we all agree on the terms, is that I'm going to be talking a little bit about cerebral blood volume. So that's the amount of blood that's in the brain. Within a typical voxel, that's like about 5% of the voxel is blood volume. The cerebral blood flow, so that's the rate that the blood is delivered to the tissue. That's about 40 to 60 mils per 100 grams per minute in healthy tissue. And then also the cerebral metabolic rate of oxygen, which is the milliliters of oxygen per 100 grams tissue per minute. And the brain is very clever about being able to maintain that cerebral metabolic rate of oxygen. And it does that by taking the smooth muscle that surrounds the arterioles and allowing that to relax in order to facilitate vasodilation and to get more blood to the surrounding tissue. And that's really one of the major things that we're measuring in reactivity, in the reactivity mapping, is how well is the brain able to modulate this blood volume. And the idea is that, at baseline, if the tissue is ischemic, those vessels will already be maximally dilated. And if you challenge them with a respiratory stimulus, they won't be able to do much. So you won't see much of a change. But if they're not maximally dilated at baseline, then you'll see them increase, and that'll show that they have some reserve capacity left. And that's more or less what we're wanting to measure. You can do that a few different ways, as we just heard about. What I'm going to be talking about today is doing it with a respiratory stimulus and the blood oxygenation level dependent, or BOLD effect. And what you'll see is we're going to give respiratory stimuli using FDA approved, so approved equipment to patients. And we're going to do this in a clinical radiology unit as a clinical protocol. The good thing, so there are pros and cons, as you just heard about a lot of the different methods. The good thing about this protocol is that, it's non-invasive, so there's no injections like acetazolamide, which is another way to raise the carbon dioxide with like a carbonic anhydrase inhibitor. It's also largely isometabolic, so that means that you don't have to worry about neuronal activity changes and that sort of thing. You're mostly looking at vascular compliance when you change the CO2 in the blood. And then also it's dynamic. So you also heard about this in the last talk, and I totally agree with that. So you not only are able to look at the reactivity, but you can look at how long it takes for those vessels to dilate and to constrict. So first, you got to think about in the clinic what sort of stimuli you will use. And there's a number of things that are out there. You can do something like hypercapnic normoxia. That's what we mostly do in the research setting. And that's where you give like 5% carbon dioxide or so forth, and you mix it with just room air, right? And you'll get a signal change generally that's about 2 to 6%, depending on what's going on when you do that. So it'll look something like this. You can also give hypercapnic hyperoxia. So that's a little bit more complex. That's 5% carbon dioxide and it's balanced with oxygen. That'll give you a larger BOLD response because you also get this non-specific response from oxygen binding in the veins. And then you can also give just, extra oxygen and so forth, which will also raise your signal in a way that's largely unrelated to reactivity. And then you could give something like acetazolamide. So why would you want to give anything other than hypercapnic normoxia? It's more complex, and that's true. The reason is because all of these agents here are FDA-approved agents. So they're approved agents, they're drugs that you can give to patients without, they're used off-label in the sense of imaging, but they're not something that is a research drug. So that's one of the kind of considerations that we have to think about when we do this in the clinic. The other thing is, you heard a little bit about these nice kind of computer-controlled rebreathing devices in the last talk. That's certainly an option in the research setting. In the clinical setting, it's a little bit more difficult to use new devices like that. So we also think about, can you just deliver the gas from like compressed cylinders with FDA-approved face masks and clinical tubing and that sort of thing. So I'm going to talk a little bit about that here as well, and whether it's useful. That's on the acquisition side. The other thing that you want to think about is how do you actually analyze the data? And what we do is similar to what was just talked about in the last talk, where you can look at like the end-tidal CO2 traces versus time. And this is for 2 different periods of hypercapnia. And those end titles go up. If you give 5% carbon dioxide, they go up by about 4 to 6 millimeters of oxygen or millimeters of mercury. And then if you look at the bold signal change in like 2 different voxels, it might look something like this. And what you can see is that in the blue region, it goes up more quickly, and it also goes up higher. And then in the red region, it takes a lot longer to get up, and it doesn't go up quite as much. So what that means is that you can actually progress this regressor in time when you calculate your Z statistics. You can either use the end tidal CO2 trace. We use just like a regressor, like a boxcar regressor, and you can progress that in time. And then you can figure out where the maximum correlation is with each voxel. That'll give you the maximum reactivity. And then you can also look at what that time is, and that'll give you the reactivity delay. So this is just an example of what that looks like for one participant, where you can calculate the maximum reactivity in this hemisphere here. You can see it's reduced through the ACA-MCA territory here, and then the reactivity delays are increased here. So it's consistent with this time course. So what we do now in all the participants is we make these maps and these movies of how long it's taking the vessels to react. This is a patient we scanned 2 days ago, left internal carotid artery occlusion near the terminus, and also has lupus anticoagulants. That's kind of interesting. And you can see that it's very easy to see not only is the reactivity delayed throughout this hemisphere, but it's also the magnitude is reduced a bit as well. So you get all of that information relatively quickly. Why is it useful to do that? Well, if you look at like a typical, so this is a patient here with a 49-year-old female with a left-sided stenosis of the internal carotid artery. It's going to be on this side. What you can see is that if you look at just a regular way a reactivity map might be calculated without this time regression, you can see that both hemispheres appear impaired. But then when you break it down into this maximum reactivity and the reactivity delays, you can see the reactivity delays are on both sides. But the maximum reactivity is actually, most impaired kind of on the left side here, on the side of the occlusion. So it gives you some additional information about whether the impairment is actually due to impaired reserve capacity or whether it's due to delayed reactivity and potentially smooth muscle dysfunction. And these maps were created with the help of our collaborators at Harvard and Purdue, Blaise Frederick and Yunji Tong. Another example of how we're using this kind of in the clinic, this is another case that happened a couple of weeks ago. This is our neurosurgeon that we work with. Patient comes in, this is now older, 67-year-old female with intracranial and extracranial atherosclerosis. You can see that they've had an old stroke here. And the concern is, they've already had an endarterectomy, so they've scraped out the plaque in the neck. And the question now is, do you want to try and do an intracranial revascularization procedure, like a bypass, which is relatively difficult. And you can see that the infogs are kind of throughout the hemisphere, except for, kind of right here in the middle. And what we did is we did the reactivity measurements again. And what you can see is if you look at that preserved region, you look at the non-infarcted region, look at the blood flow and the maximum reactivity, you can actually see that it's pretty well preserved in between those regions of the infarct. And this is a case actually where the reactivity scan was used, not to decide not to do surgery. So the surgeon says, interesting scan. I ended up not offering any surgery. She has fairly debilitating symptoms from her previous stroke, so not sure how much benefit we can get from a surgery with the rest of the cortex with normal reactivity. So another example of, reactivity mapping actually being used to affect management of patients. I want to talk for the rest of the talk a little bit about some of the trials that we're doing in patients with Moyamoya disease. And if you're unfamiliar with this condition, this is a non-atherosclerotic intracranial stenosis. In many people, it's idiopathic, so that means it's not secondary to anything. You just develop it. It's most common in females, average age of about 41 years. You can also get it as a syndromic secondary condition to things like sickle cell, Down syndrome, and so forth. What happens in these patients is you get steno occlusions, a narrowing or occlusion of the supraclinoid internal carotid arteries or the proximal branches. So it's an intracranial vascular stenosis. You get narrowing of the intracranial vessels. And as a result, your brain will develop these kind of collateral vessels to kind of circumvent that stenosis, and they look like a puff of smoke on a catheter angiogram like that. So that's where the name Moyamoya comes from. It means puff of smoke in Japanese. And the question in these patients is, are they compensating well through these new vessels or not? And if they're not, what you can do is you can do a surgical revascularization, which I'll talk about here as well. And that revascularization, it's pretty interesting. So what they do is they'll open up the skull, and they'll take a branch of the superficial temporal artery and they'll lay it onto the brain. And over time, what that does, if it works, is it will promote angiogenesis. You'll get growth of new blood vessels in that region. So it's neoangiogenic. The issue with it is that it doesn't always work. So you get, if you look, a year later at a lot of these patients and you look at their catheter angiogram, it'll look something like this. So you don't really see sprouting of many new blood vessels. Sometimes they'll sprout a little bit more, and then sometimes you'll get a really good response, or really more than 1/3 of the MCA territory will have new blood vessels that have sprouted. So the question is, can we monitor this, with reactivity mapping or so forth? And then even better, can we predict who's going to have good responses and who's going to have progressive strokes and whatnot? So this is an example where we did 26 patients. These are 2 of them that I'm showing here. Here's an example of a robust revascularization, so before and about a year after, and you can see the new vessels that have formed here. This is in contrast to a patient that really didn't have a good response. If you look after, you don't see as many new vessels forming here. And what's nice is if you look at these reactivity maps, you can see them in the person that had a good response. Reactivity actually doesn't change too much here, but it's actually not too much delayed or impaired here before. Afterwards, you can see the delays go way down. So that's nice. And then you can see that in the person that didn't have as good of a response, those maps don't actually look that different between the 2 time points. So it's kind of confirmatory for the angiograms. And that's nice because you can't really do surveillance angiograms in these patients, right? You have to inject contrast. There's a risk of stroke. So you give a non-invasive way of monitoring these patients. It's great. And what we did when we analyzed this is we looked at how the reactivity changes in those before versus after surgery, and those that have good revascularization responses on angio versus poor. And you can see that the reactivity goes up in those that have good responses. Interestingly, the maximum reactivity doesn't change that much, but the reactivity delays go way down afterwards. So it provides some evidence that you can use these imaging techniques to look at revascularization responses similarly to catheter angiograms. This is just an example of what these maps look like. So we scan these patients about every 6 months or so now. You can see before the reactivity delays are quite long, start to get better with angiogenesis, and then they go way down after like 12 months in a good case. These are maps that were created by Blaise Frederick at Harvard. Okay, so that's kind of showing that you can see similar things with the catheter angiograms. But one of the things you want to know is, can we actually predict who's going to have a good response or not? This is work that was done in the lab by Spencer Waddle, and it was just published. So what he did is he looked at those that had good responses, pre versus post revascularization, versus poor responses. And he enrolled 31 idiopathic patients. That includes 40 revascularized hemispheres. So they sometimes revascularize both hemispheres, often actually. And then he looked at, were there any pre-surgical indicators on the reactivity maps that corresponded with good versus poor outcomes? And I've just kind of shown the characteristics of the cohort here. These are all clinically indicated scans. And what you see is that those that have good outcomes, they have a larger reactivity in the posterior circulation. That's often preserved in more and more patients. And then they also, if you smoked, you did worse. If you were a male, you did worse. And then Black participants versus white participants also had worse responses. These are just kind of examples of what those images look like. So this is somebody with a poor response and a good response on the right. You can see the flares showing the infarct regions here. Both were pretty similar in terms of vasculopathy. So they both had a near occlusion of the M1 segment on the right side. This is the coronal view. Anatomical scans don't look that different, which is typical. And then when you look at the maximum reactivity in the poor participant, you can see that's a little bit lower in the posterior circulation versus in the good participant. And if you look at those reactivity delays, you can see that they're a little bit longer in the person that had a poor response versus the person that went on to have a good response. But they are subtle, like they're not blatant, they're subtle effects. But it's potentially, looking at the health of the posterior circulation could be useful in portending outcomes. These are just the group results shown here, looking at how the maximum reactivity varies in those that have poor versus good responses. Also the delays going down, not quite significant, but you can see that trend there. And then also if you're older, you tend to have worse responses as well. So younger people did better. And then, really the dream with all of this is not just to be able to use it for surveillance, but to be able to say, can we look at the reactivity parameters and predict who's going to have a new infarct? So the idea is that these are 2 of our patients. You'd bring them in, you'd measure the blood flow, maybe the reactivity delays, the reactivity. You'd look at their flare for infarcts, follow them up 2 years later. They don't have any new infarcts. And then you take someone like this that has low blood flow in the right MCA territory, maybe evidence of delayed response times, lower reactivity, and then they go on and they develop an infarct in that same region. So that's really what we'd like to do. And that's a real patient. Those are 2 real patients, but they're unfortunately not all as nice as that. So we had a postdoctoral fellow, Meher Jadakonda, who's now at MGH, who looked at this in 43 participants who we followed for about 1.5 years or so. And what he did is he went in and he segmented out which ones had new infarcts on flare, and you can measure that. And then it's a little bit tricky because the blood flow and the blood volume are different in the gray matter and white matter. So about 2.5 times higher in the gray matter than the white matter. So what he did is he created this laterality index. So he said, I'll look at the hemodynamic parameters in the infarct region and I'll compare that to the contralateral side as kind of a comparison, and that might control a bit for partial volume effects and whatnot. And he figured out, how many of these patients, these were all graded by a neuroradiologist, went on to have new infarcts, and he calculated these kind of affected versus unaffected laterality indices. And what do you see? Well, if you look, at grouping the hemispheres by stenosis, that's great. We always show this in the paper. It looks really good. So the reactivity is always lower. When you look at the stenonic hemisphere, that's radiological right here. Maximum reactivity is lower. The delays are super long. And the question is, does this correspond with those that develop new infarcts? And what you see is it's not so easy, actually. So if you look at the cerebral blood flow, those that had infarcts versus those that didn't, not significant. There's a wide range here. Same thing for the maximum reactivity. Didn't see a significant difference. What we did see is if you look at the reactivity delays. So those that developed infarcts had much longer reactivity delays than those that did not develop infarcts. So it's evidence that, not only looking at the maximum reactivity, but also looking at these delays can be really, useful and prognostic probably going forward. So just to conclude, so I went over some considerations for clinical cerebrovascular reactivity mapping. So you got to think about the correct application, really where you can use the information to change management. And you've got to get support from, really neurology and neurosurgery. They're the ones managing those patients. I showed some case examples of how you can, use on a single case, reactivity to really affect care in patients. And this is one example where I think, we actually don't do a lot with BOLD in our lab. We use mostly other quantitative methods, but I think really for reactivity imaging, BOLD is quite good and can also be useful on a single case basis for, interpreting the physiology of a patient, which is very difficult, with functional connectivity and neurologic and neuro applications. Right. And then, I showed some examples of how you might be able to use this to affect surgical revascularization decisions. We also do it in sickle cell to affect stem cell transplants and transfusions. So I didn't go into that today. And then also I showed some results of our kind of ongoing clinical trials where we show that, reactivity parameters can correspond with gold standard catheter angiography. So that can make it useful potentially for surveillance and whatnot, non-invasively. Also that the reactivity of the posterior circulation, at least in patients with non-atherosclerotic intracranial stenosis, it might have relevance to sort of predicting or identifying which patients have the best revascularization responses. And then finally, showed some evidence that cerebrovascular reactivity delays, could be really important for predicting infarct development in some of these patients, maybe just as much or even more than the blood flow or the reactivity itself. And that should be considered, in some of the protocols as well, I think. So I'll just end with a thank you to all of the people that are involved in this project from neurology, neurosurgery, radiology, and then people of our team. And this is a picture of my group as well from a couple of years ago before COVID. So yeah, thank you for your attention.
All right, thanks a lot, Dr. Donahue. Really, really interesting talk. So Chris, are there any questions?
Yes, thanks. We have one question so far from Beth York. She was wondering if whether conditions like multiple sclerosis that were discussed earlier today can affect CVR or vasculature in general.
So we do quite a bit with neurodegeneration, not so much with multiple sclerosis with reactivity imaging. So I could speculate on it, but I would probably not be the right person to answer the question about MS specifically. It's certainly you could certainly do it in patients with MS. I'm guessing that the reactivity profiles would be more subtly impaired than they would be in cerebrovascular disease, obviously. So you need, very controlled protocols to look at that. But, as you probably know as well, there's ongoing evidence to support that things like, neurofluid circulation and lymphatic dysfunction are relevant to things like MS and immune disorders. And if that's true, a big component of that pathway is perivascular flow, which would be dependent on vascular health and vascular profile. So, I think others in this conference might be more qualified to answer that question. It could certainly be done, and it's very logical that there would be subtle differences there, I think.
Thanks. No other questions yet from participants.
Okay, I have one question in the chat on my end. So it's Anuran Karatai who asks, regarding quantitative CVR calculation, how do you overcome the possibility of NAN, so not a number, voxels, due to CO2 time series delay mapping with cross correlation?
Good. Okay, so I think that the question is generally, what's the best way, I guess, to do the time regression analyses? And if you get nonsensical numbers, how do you deal with those numbers, I guess? So we looked at this a few different ways, and the last speaker went into it as well. What we do is we regress something similar to a boxcar regressor in time, and we don't actually use the end-tidal CO2 generally as the regressor. And the reason is probably similar to what you're getting at, is that the end-tidal CO2 measurements, when they're perfect, they're great. And if they're not perfect, then they add a lot of noise to the measurement, and often they're not. So different things can happen with, whether you measure inside the mask, whether you measure outside, which is better. So what I would recommend, if you're getting that issue with your setup, is that you maybe don't use the end-tidal CO2 regressor itself. You use a boxcar regressor, or you can use the global, signal change or something like that as a regressor. And we actually we measure and monitor end-tidal CO2s, but we don't actually use the end-tidal CO2 trace as the regressor anymore, because it just adds a bit of noise, we found. So if you can get it to be super controlled and everyone cooperates, it's probably better to do it that way. But generally, we use something similar to a boxcar regressor that we progress in time. And for this application, that works very well. In other applications, you might need something more specific.
Okay, thank you. So Chris, are there any more questions in the chat?
No more.